There's a lot of discussions between equality and equity. And I think when we're looking at equality, it's giving, everyone the same things and saying, okay, carry on. And equity is really ensuring that people are receiving what they need.
Every man is different, and it's really important for us to tailor our interventions to the needs of diverse men. And this is especially important when we think about inequities in suicide, or unfair and avoidable differences in suicide among men.
A lot of my work is in sub-Saharan Africa, and we had been talking amongst ourselves in the global mental health field about where are the men? A lot of people gave anecdotal evidence about having interventions that they were providing, and mostly women were attending those interventions.
If we're thinking about healthy communities, men are part of these communities, and they're often a group that may be, excluded because we are focused on different populations.
When thinking about the main mental health needs of LGBTQ2+ people, young queer and trans men in particular, it's important to acknowledge that this is a group who faces inequities or unfair differences in health when it comes to mental health and well-being. And there are some common struggles or experiences. And one of these common challenges is the social stress, isolation, and shame that young queer and trans men can face when they're growing up in an environment where homophobia, transphobia persists today.
It's very clear that the prevalence of suicide among people living with HIV is incredibly high. So what happens in Malaysia is that when it comes to sexual health services, like HIV testing, HIV treatment, a lot of the time, a lot of these men do want to access these services, but because of various forms of stigma, for example, stigma associated with the LGBTQ+ community, and that is further compounded by HIV-related stigma. All of that leads to a lot of these men not being able or not feeling confident or safe enough to access mental health services and other forms of services. The other thing as well is the lack of LGBTQ+ sensitive training among healthcare practitioners like doctors, nurses, mental health practitioners. They don't have that training, so it becomes a challenge for this group of men to access a service that is equitable and non-judgmental. So for a lot of these men, they're constantly trying to decide, do I just not go and get the services, or do I just stay at home, or do I risk going and engaging in the services and potentially facing a lot of this criticism and judgment?
There was, consistent feedback in the community saying, okay, we're doing great work around trauma and violence-informed physical activity for mothers, but there's nothing there for the fathers. We've seen in the work that we've done that, you'll receive funding for a certain duration of time, and you're able to co-develop these programs and implement them, and you can demonstrate their success. But when we don't have those long-term strategies in place to sustain that program, that's when it becomes, really, really problematic and challenging. The lack of consistency is what also is hugely problematic and contributes to sort of exacerbating those inequities. We lose folks along the way because they often don't want to show up if they're just like, okay, here's just going to be these, once-off program for a few months and then it's gone. I think there really needs to be that trust and sustainability piece that is built into programming.
One of the first things that we need to do, we need to start listening to what these men have to say. We need to reach out, sit down and listen to what their experiences are like, about what works for them, about what challenges that they're facing. I think that's a strength-based approach that we need to really adopt in the work that we do if we want to help these different marginalized communities, because they do have a voice, but oftentimes their voices are not heard, or their voices are overshadowed by a bunch of different things. Because again, in research, in academia, or just in general, we tend to ask a lot of questions, but we don't always listen to the answers that we get.
It's critical that we take a comprehensive and upstream approach to mental health promotion and to suicide prevention. And this needs to involve taking interventions on multiple levels. So for example, we need to be working with individuals, so young people, their peers, their service providers, and designing services and interventions at that level. We also need to be working at the community level, like making schools and workplaces more queer-friendly and gender-affirming for folks. And we also need to be working at the structural policy level, so working to make our social safety nets and supports more accessible and more available and more robust, especially for folks who may have unequal access to social determinants of good health. And while I think suicide prevention is critical, I think we can take that a step further and really emphasize the need for mental health promotion. So recognizing that everyone has mental health and it's something that we should be promoting for all people and for society at large.
When we're thinking about co-developing programs or implementing programs, I think equity really has to be central to what we're doing. This means really listening to what the community wants and rethinking how we want to co-develop programming or improve access to resources. If we're trying to develop these very large homogeneous programs, we're going to continually let certain groups or communities fall through the cracks.
We really need to think about how to change our services from a traditional hospital-based kind of service that we think of and often deliver in Western context to be much more flexible and community-based. So we are doing some of that work in Mozambique with community health workers who can go to homes in villages and deliver brief interventions in those settings. So it makes it much more accessible and also can reach people where they are. What we heard about in some of our qualitative interviews in terms of engaging men in mental health services in Mozambique was that even, the hours of the hospital might not fit work hours. And this was quite problematic for men because work is a high priority, as it is in many settings, that they're not going to miss work for a mental health intervention. It's meant a lot to be a part of this team. I feel like I've gained an incredible amount of knowledge. And, the core of what binds us is this interest in engaging men in mental health services, but we all bring a different lens or a different area of focus in our work, and just hearing about people's projects and how they're applying masculinity's lenses to their work has been extremely fruitful for my own endeavors.
Ultimately, in my view, we need to be working to intervene on these social conditions and make our societies and systems more livable and more supportive. And we can draw on a range of tools to do this, and these are many of the tools that I've been learning about through my work with the cluster. So for example, using different critical theories and methods, using targeted interview questions and prompts, really leveraging community strengths and assets, and of course, drawing on focused knowledge translation activities and really action-oriented work to advance equity with young queer and trans men and all LGBTQ+ people in the area of suicide.
So I see it as an opportunity for me to not just come here and rely on experts to help me do the work that I want to do, but to also share and educate the people here about the different groups of men that exist in other parts of the world. And I think that's really important for academia, especially within men's health research, when we talk about masculinities, when we talk about men's health. And we want to talk about equity within those domains. We need to think and include different groups of men, not just within Canada, but from different parts of the world. I came to Canada with those two main ideas: to learn from people who has extensive amount of experience in this area, and to take on that role to educate the people here and to let them know this is a thing, this is an issue that's happening on that side of the world, and this is an issue that resonates with a lot of other countries like Malaysia. I've been able to speak to so many people, I've been able to connect with other PhD students, other researchers, and I've been able to share my stories and my experiences with people from the US, from Australia, and even from Canada. So it's a really fun process and I'm really enjoying it, and I'm looking forward to keep doing this throughout the course of my program.